Hello, I'm Dr. Amit Porwal, Head Glaucoma Services, Choitram Netralaya, Indore, and Member Scientific Committee of All India Ophthalmological Society. Today, I'm going to talk on minimally invasive glaucoma surgery, the BANG procedure, which is bent ab-interno needle goniectomy. I have got no financial disclosures to disclose. So we all know that trabecular meshwork and the inner wall of Schlemm canal are the site of greatest resistance to aqueous outflow. Augmentation of the conventional outflow pathway can facilitate the physiological outflow and subsequently lower intraocular pressure. The most recent approach to enhancing the conventional outflow pathway is via an internal approach to the trabecular meshwork and Schlemm canal. That is, increasing aqueous outflow from trabecular meshwork and Schlemm canal by tissue removal by a procedure called BANG, which is bent ab-interno needle goniectomy. Dr. Arsham Sebani was the first to describe the BANG technique. So basically, the BANG technique consists of excision of the trabecular meshwork tissue. It bypasses the trabecular meshwork and forms a direct pathway to Schlemm canal for 3 to 4 or more clock hours. It can be performed combined with cataract surgery or as a standalone procedure in phakic, aphakic, or pseudophakic patients. Now, coming to the indications for Phaco plus BANG procedure, basically cataract plus any of the following indications. Patients with mild to moderate glaucoma cases, primary open-angle glaucoma, pigmentary glaucoma, pseudo-exfoliation glaucoma, ocular hypertension, normal tension glaucoma, secondary open-angle glaucomas, primary angle closure glaucoma, secondary angle closure glaucomas combined with goniosynostosis, advanced and refractory glaucomas, IOP not reduced even after maximum medical therapy and laser trabeculoplasty when the patient is non-compliant to treatment or when there is an adverse drug reaction to the anti-glaucoma medications. The contraindications being cataract plus any of the below indications, which is active neovascular glaucoma, corneal opacity, angle dysgenesis, elevated epithelial venous pressure, examples Sturge-Weber syndrome, thyroid eye disease, or retrobulbar tumors. So an ideal candidate for Phaco plus BANG is cataract plus below indications. That can be the patient should have mild to moderate open angle glaucoma. The goal should be to decrease the IOP by 20 to 30% or in mid-teens, or to reduce the number of glaucoma medications. What equipments we need? We need basically the Phaco instruments to complete the cataract surgery. Then we need a surgical gonioscope and a cohesive viscoelastic substance. BANG is the only low-cost mixed procedure available in the world. All you need is a 25 gauge hypodermic needle, which is 5/8 inch is preferred, and a needle holder is used to bend the tip. A goniotome is fashioned by bending the distal 1 millimeter of the needle towards the bevel at about 75 to 80 degree angle. This can be used to perform a goniectomy for about 120 degree using a gonioprism. Surgical steps for BANG being after phaco and IL implantation, antechamber is filled adequately with cohesive visco. To get an enhanced image of the nasal angle, microscope is tilted towards the surgeon by 35 to 40 degree, while the patient's head is tilted away from the surgeon by 35 to 40 degree. By doing this, we get an enhanced view of the angle when the gonioscope is placed over the cornea. So after applying viscoelastic on the cornea, especially a cohesive visco is applied, you can place the Swan-Jacob gonio lens on the cornea. Then the needle goniotome is then introduced into the anterior chamber, first in low magnification and then in high magnification once you have identified the angle structures. The central point of the nasal angle is penetrated with the tip of the needle. Thereafter, the needle is advanced for at least 60 degrees in the superior and inferior directions. Goal is to excise the pigmented part of the trabecular meshwork and expose the Schlemm canal into the anterior chamber by 120 degrees. A blood reflex at the ablation site indicates appropriate depth has been reached in the trabecular meshwork. So this is a small video which shows how to prepare the needle for the BANG procedure. So an IOL is implanted after cataract phacoemulsion in the cataract. A needle 25 gauge needle is taken. Distal 1 millimeter is bent with the bevel facing towards you by 75 to 80 degree, and this is the way needle is fashioned. This is the procedure of BANG. So once the needle is fashioned, you position the patient and the microscope, place a cohesive visco over the cornea, place the gonio lens. First, identify the structures in low magnification, then increase the magnification. The needle is introduced into the trabecular meshwork, and with a swiping movement, gently about 50 degree or say 50 to 60 degree inferiorly and then 50 to 60 degree superiorly, trabecular meshwork is cut. Or you can go when one go from superior to inferior. You can see when I'm cutting the trabecular meshwork, there is a oozing of blood. That means the right plane has been reached, and this is a good sign. So once this is done, whatever blood which is there, you can wash it with the help of a biomedical irrigation and aspiration. Sometimes what happens is basically you can get a trabecular strip which can be stripped off with the help of a microrhexis forceps. You can see this was the trabecular strip which was there. So with the help of a microrhexis forceps, it has been stripped off. This is another case. Same thing after doing cataract surgery. Place the cohesive visco and the gonio lens over the cornea. First, identify the trabecular meshwork in low magnification, then in high magnification. Position the trabecular bang needle into the trabecular meshwork and swipe it inferiorly. You can see as I'm swiping it, there's a reflex of blood, and I'm always in the trabecular meshwork plane. You don't go too anterior or too posterior and swipe it inferiorly. Now you can go again, reposition the needle superiorly, and then start the cutting of the trabecular meshwork again and join the initial cut. So this is called a meet and greet method, and this way the trabecular meshwork is cut. Basically the exercise, and you again do the body wash. You again do the bimanual irrigation and aspiration. And in the same video, another case, I'm showing that there was a trabecular strip which is removed with the help of a micro-access forceps. You can see the trabecular meshwork which has been removed, stripped off after being cut, and this is the way you are going to do the bang procedure. Sometimes what happens is when you're doing this procedure, there you can see in this case, basically, because of the visibility effect, there was some pressure on the cornea, and after the trabecular bang is done, there was a lot of oozing. So nothing to worry. This is a good sign. But sometimes when the patient, especially in anticoagulants, you get a lot of oozing. So with the help of a continuous irrigation aspiration, you can wash off the blood. You should never put air because you don't want the fibrinous membrane to be there or the ankle to be blocked. So continuous irrigation aspiration will give a continuous hydrostatic pressure, and the bleeding will be arrested. This is another case in which the bank procedure was done. The visibility, sorry, please excuse me for the poor visibility of the camera. So after the trabecular meshwork is done, you saw when I'm doing the bimanual irrigation and aspiration, suddenly what I noticed is there was a Descemet's membrane detachment. Now you can see when I was doing the hydro, this is a pear-shaped Descemet's membrane detachment. Nothing to worry. This is because you are not in the your needle is not in the right plane. So inject air and just tap it over the cornea so that the DM gets deposited. And this pear-shaped detachment is very common in bang if your positioning is not correct. So positioning of the needle into the trabecular meshwork is very, very important. So basically, the bevel and the lumen of the hypodermic needle combine to form two cutting edges, in effect creating a double blade goniotome capable of excising tissue in block. The dorsal portion of the bent needle acts as a guard, preventing incision of the posterior wall of the Schlemm's canal and helps in maintaining the plane of excision. The only disadvantage is damage to the surrounding tissue due to the sharp needle can occur. Bleeding during excision of the trabecular meshwork is a good sign, but if it is not in the correct plane, there can be an excessive bleeding. Reattachment of the trabecular meshwork leaflets causing cleft closure can be there. So it is always better that whenever you see the trabecular meshwork leaflets, as I showed you in the video, with the help of a micro-access forceps, you just strip it off. IOP reduction is limited by epistolar venous pressure and Schlemm canal resistance, causing early failure of the surgery. These are the few disadvantages. Complications, hyphema is the most common complication whenever you do this goniotomy procedure, especially with the band needle. But nothing to worry, as I told you, with the help of a continuous irrigation and aspiration, the pressure can be increased and you can have hemostasis. Post-operatively, there can be hyphema, but it resolves within 4 to 5 days. And if it is severe hyphema, then you have to take the patient for AC wash. Other complications can be peripheral anterior syndicate. There can be a transient IOP elevation. There can be post-operative inflammation, sometimes hypotonesis and cyclodysis cleft is noted. So when we look at the rate of complication, ab-interno approach has generally shown to be safe with a complication rate of 4.3% compared to 35.3% of the traditional ab-externo trabeculectomies. Once the bank procedure is done, usually you can ask the patient to come for follow-up on day 1, week 2, and then at the surgeon's discretion depending on the patient's progress. Checking the IOP at every visit is a must. So coming to the published literature of bang procedure. The recent study which was published in the Indian Journal of Ophthalmology by Bouquet et al. Along with Dr. Tanuj Datta, they studied the outcomes of bent ab-interno needle goniectomy with phaco emulsification in moderate to severe primary open-angle glaucoma. This was a single-arm prospective international study in which 32 patients were included. All patients underwent bang using a 26-gauge needle to excise 30 degrees of the trabecular meshwork along with the phaco, and the primary outcome was IOP. Secondary outcomes were success rate, percentage reduction in IOP and anti-glaucoma medications, and intraoperative complications. So at 12 months, they noticed a significant decrease in IOP along as well as anti-glaucoma medication, and overall success at 12 months was achieved in 87.5% of the eyes. They concluded that 30-degree bang with phaco in patients of primary open-angle glaucoma appears to be a safe, effective, and affordable mixed procedure for developing countries. There is another study published by Kim et al. They compared combined phaco and conventional goniotomy with phaco alone in open-angle glaucomas, in which the mean IOP and number of medication at 3 months, 6 months, and 12 months after the procedure was evaluated. The drop of IOP was significantly higher in the combined surgery group at 3 months, 6 months, and 12 months. The decrease in medication was also higher in the combined surgery group. This study showed the efficacy of goniotomy despite the use of traditional methods. Schlemm et al. Published a 6 months outcome of combined conventional needle goniotomy and phacoemulsification eyes with early to moderate primary open angle and pseudo-exposition glaucoma and ocular hypertension. 32 eyes of 30 patients were enrolled. There was a 25.2% and 32.1% reduction in IOP at 3 and 6 months after the procedure, respectively. Meanwhile, the decline in medication was 66.7% at the same points at the same time points. The decline in medication was 66.7% and 50% at the same time points. In conclusion, this study revealed the efficacy of combined phacogoniotomy with the needle in eyes with coexisting cataracts and early to moderate open angle glaucoma. Also, this procedure is effective in reduction of IOP and the burden of topical eye medications. Sutte et al. Did a retrospective review of all patients who underwent goniotomy using a modified hypodermic needle and concluded that the bank procedure is a low-cost mixed technique available to the surgeons around the world with preliminary outcome similar to the most expensive alternatives. So to conclude, minimally invasive glaucoma surgery, bent ab-interno needle goniectomy, that is a bank procedure, provides a safe new option for IOP reduction and reducing the number of anti-glaucoma medications. It has a low risk, low cost, and preserves tissue. Because of the above factor, bank has gained popularity in the developing countries. Thank you for your patient hearing. For any queries, I am available on the following mobile number, and you can also email me at amitcporwal@gmail.com. Thank you.